Welcome to the Physician-Focused Payment Model Technical Advisory Committee, or PTAC. We are pleased to have you all here today. In addition to the members of the public here in person, we also have participants watching the live stream and listening in on the phone. This is the PTAC's fourth meeting that will include deliberations and voting on proposed Medicare physician-focused payment models submitted by members of the public. We would like to thank all of you for your interest in today's meeting. In particular, we would like to thank the stakeholders who have submitted models, especially those who are here today. Your hard work and dedication to payment reform is truly appreciated. PTAC has been very active since our last public meeting in December. Since that meeting, we have submitted recommendations and comments on 6 physician-focused payment model proposals to the Secretary of Health and Human Services that were voted on at the December meeting. These 6 reports are now available on the ASPE PTAC website. And of course, we've been very busy reviewing and evaluating physician-focused payment model proposals from the public. And I'd like to take a moment to recognize Mary Ellen, Ann Page, and the staff for the incredible work that they're doing supporting this committee because of the volume of activities and supporting all of us as members of the committee. We're very grateful for that, so thank you. In addition, the recently enacted Bipartisan Budget Act of 2018 grants PTAC new authority to provide initial feedback to submitters of proposed models. We've been considering how to operationalize this new authority, and we'll share our plan with the public soon. PTAC is also looking forward to working with Secretary Azar. Secretary Azar has identified value-based transformation of the healthcare system as one of his top priorities, and we believe that the proposals we are receiving and our comments and recommendations on them can support this effort. I am pleased to report that interest in submitting physician-focused payment model proposals to PTAC continues. Since PTAC has first began accepting proposal models for review on December 1st, 2016, PTAC has received 24 full proposals and an additional 13 letters of intent to submit a proposal. The proposals represent a wide variety of specialties and practice sizes, and they propose a range of payment model types. We are pleased that we have so much interest from clinical stakeholders in proposing physician-focused payment models, and we're fully engaged to ensure proposals are reviewed carefully and with the needs of both clinicians and patients in mind. We are already looking ahead to the agenda for our next public meeting, which will be held here in the Great Hall of the Humphrey Building, June 14th and 15th. One simple reminder, to the extent that questions may arise as we consider your proposal, please reach out to staff through the PTAC at HHS.gov mailbox. The staff will work with me as chair and with Elizabeth, the vice chair, to answer your questions. We have established this process in the interest of consistency in responding to submitters and members of the public, and appreciate everyone's continued cooperation in using it. Today, we will be deliberating on 3 proposals, and we will deliberate on 1 proposal tomorrow. To remind the audience, the order of activities for each proposal is as follows. First, PTAC members will make disclosures of potential conflicts of interest and announcement of any committee members not voting on a particular proposal. Second, discussions of each proposal will begin with presentations from the preliminary review team, or PRTs. Following the PRT's presentation and some initial questions from PTAC members, the committee looks forward to hearing comments from the proposed submitters and then the public. The committee will then deliberate on the proposal. As deliberations conclude, I will ask the committee whether they are ready to vote on the proposal. If the committee is ready to vote, each committee member will vote electronically on whether the proposal meets each of the Secretary's 10 criteria. The last vote will be on an overall recommendation to the Secretary of Health and Human Services. And finally, I will ask PTAC members to provide any specific guidance to ASPE staff on key comments they would like to include in the report to the Secretary. A few reminders as we begin the discussions of the first proposal. PRT reports from 3 PTAC members to the full PTAC. These reports do not represent the consensus or position of the PTAC. PTAC reports are not binding. The full PTAC may reach different conclusions from that contained in the PRT report. And finally, the PRT report is not a final report to the Secretary of Health and Human Services. PTAC will write a new report that reflects deliberations and decisions of the full PTAC, which will then be sent to the Secretary. It is our job to provide the best possible recommendations to the Secretary, and I have every expectation that our discussions over the next 2 days will accomplish this goal. I would like to take this opportunity to thank my PTAC colleagues, all of whom give countless hours to the careful and expert review of proposals before them. Thank you again for your work, and thank you to the public for participating in today's meeting in person, via live stream, and by teleconference. So let's go ahead and get started. The first proposal we will discuss today was submitted by the American Academy of Hospice and Palliative Medicine, AAHPM, and is entitled Patient and Caregiver Support for Serious Illness. So PTAC members, let's start the process by introducing ourselves. At the same time, read your disclosure statements on this proposal. So why don't we start with Dr. Meadows.
Dr. Rhonda Meadows, Executive Vice President, Population Health, Providence St. Joseph Health. I have nothing to disclose, Mr. Chairman.
I'm Bob Berenson from the Urban Institute, a fellow at the Urban Institute. I have nothing to disclose.
Kavita Patel, internist at Johns Hopkins and a fellow at the Brookings Institution, and nothing to disclose.
Lynn Nichols, I'm a health economist from George Mason University, and I have nothing to disclose.
Elizabeth Mitchell, Network for Regional Healthcare Improvement, nothing to disclose.
Jeff Baylett, Executive Vice President of Healthcare Quality and Affordability with Blue Shield of California. I have nothing to disclose.
I'm Mary Ellen Stallman. I'm the ASPE team lead for PTAC.
Ann Page, I'm designated federal officer for the PTAC committee, which is a committee that has to comply with the Federal Advisory Committee Act.
Bruce Steinwald, health economist here in Washington, D.C. Nothing to disclose.
Paul Casal, cardiologist and executive director of New York Quality Care, the ACO for New York Presbyterian, Columbia, and Weill Cornell. I have nothing to disclose.
Good morning. I'm Harold Miller. I'm the president and CEO of the Center for Healthcare Quality and Payment Reform. I provided assistance to AAHPM in the early phases of its development of a payment model for palliative care. I was not involved in the preparation of this specific proposal, but I'm going to recuse myself from voting on it.
Good morning. I'm Grace Terrell. I'm a practicing general internist at Wake Forest Baptist Health and the Chief Executive Officer of Envision Genomics. Nothing to disclose.
Tim Ferriss, CEO of Mass General Physicians Organization. Nothing to disclose.
Thank you. I'd now like to turn the microphone over to Dr. Paul Casal. He is the preliminary review team's lead to present the PRT's finding to the full PTAC.
Great. Thanks, Jeff. So as I go through these slides, there's quite a bit of information on each slide. I'll just be highlighting specific points and not reading through each of them. So this is just a reminder and summary of composition and role of the PRT, and Jeff has already described that. So this proposal overview is a 5-year demonstration, and it's focused on palliative care services. Participating beneficiaries must meet detailed diagnostic and functional status and utilization criteria in 2 clinical complexity tiers. Payments, there are 2 tier-based monthly care management payments and 2 different financial incentive tracks. So some of the specifics around the proposal, Tier 1, and again, a lot of information. I just wanted to highlight a couple of things. In addition to the clinical health conditions listed at the top, you can also are eligible if you have 3 or more chronic conditions from the Dartmouth Atlas. In terms of functional status, they're split up into non-cancer and cancer diagnosis in terms of the criteria. And finally, on health utilization, one significant utilization in the past 12 months, either ED, obstay, or inpatient hospitalization. To get into Tier 2, which is a higher complexity, it excludes dementia as a primary illness. Again, the functional status is separated into non-cancer and cancer diagnosis, and again, the functional status criteria are lower for Tier 2. And healthcare utilization is increased in that there is at least one inpatient hospitalization in the past 12 months and either a second hospitalization or an ED visit or an obstay. So continuing with the overview in terms of palliative care services, you can see they are listed there. I just wanted to highlight on the services delivered by the palliative care team, it must include the team, a physician, a nurse, social worker, and spiritual care provider. There are other members who may be part of the team. And just to highlight on the certification, one core interdisciplinary team member must be certified, but it's, to clarify, not required to be the physician or the nurse practitioner. Any of the team members can be certified. And in terms of payments, the palliative care team, or PCT, are the APM entities, and they receive the payment. They can be independent provider organizations or associated with, as you see listed there, hospices, home health organizations, et cetera. And there is payment differences based on the tiering and the track. So again, a lot of information here, just to highlight a couple of things. Tier 1, the base payment is $400 per beneficiary per month. Tier 2, $650. And again, there are other adjustments as previously described in the slides. The per beneficiary per month payment replaces E&M payments. However, providers that are not part of the PCT continue to receive E&M and other payments, but cannot bill for CCM, chronic care management, or complex CCM codes. As I mentioned, there are 2 tracks in terms of the financial incentives. Track 1 is positive and negative incentives of up to 4% based on the total per beneficiary per month payments received for the year. Track 2 is based on shared risks, shared savings based on the total cost of care. And then the risk-adjusted benchmark limited to the lesser of 3% of total cost of care, or 8% of each PCT's total Medicare A and B revenues. Shared savings is capped at 20% of total cost of care benchmark, and all of this is dependent on performance on quality measures. In terms of the quality standards, again, it lists their minimum participation standards, and just to highlight, they must have at least one face-to-face visit with each patient monthly is the minimum participation standard. In terms of the quality measures, years 1 and 2, the PCTs are required to report only, payment not tied to performance on the 15 measures. And in year 3, PCTs are accountable for the quality performance. So I'm going to go through all of these individually, so I was not going to sort of go through them at this point, so I'll just go through each one. So for criterion 1, scope, the PRT conclusion was that the proposal meets the criterion and deserves priority consideration. And again, there's a listing here of why we feel that having expanding the scope as it relates to palliative care is important. Certainly we know there's a need, and the current Medicare hospice benefit and Medicare Care Choices demonstration have significant limitations as regards to the number of patients who may be eligible. And so the PRT agrees that palliative care should be more widely available Medicare benefit. And so for these reasons, the PRT finds that this proposal model meets criteria 1 and deserves priority consideration. On criterion 2, quality and cost, PRT conclusion was that the proposal does not meet the criterion, and the PRT has significant concerns about how quality is measured and monitored. So one of our concerns was around this insufficient outcome measures. There were only 2 outcome measures described, adequacy of treatment for pain and symptoms and help with pain and trouble breathing. PRT felt there was a need for more robust outcome measures. PRT was also concerned about the timing of the measures. The measures described were limited to quote-unquote front and back end of service. So it's through an admission survey, completion of activities within 15 days of enrollment, and then after death. The PRT also had concerns about insufficient utilization measures. Of the 3 proposed measures, 2 address hospice utilization and 1 addresses ICU days. So the concerns included that there were no reliable benchmarks for these utilization measures and the potential risk of unintended consequences when attempting to reward cost reduction from decreased utilization. The PRT was also concerned about the potential variation in PCTs and minimal standard for contact with beneficiaries. As I already stated, the minimum was once a month, face-to-face, and the degree of clinical expertise in palliative care potentially could vary depending on which provider type has the certification. Further concerns around the payment methodology as it relates to cost. The PRT was concerned about potential susceptibility to bias in beneficiary enrollment decisions and potential to incentivize enrollment of patients expected to be lower cost. There was concerns about the interaction of this model and hospice care. The PRT had concerns of the risk of potential upcoding patients to the higher tier 2, which is the $650 per member per month versus $400, may potentially incentivize assigning beneficiaries to the high complexity tier. And there were no specifics on how spending benchmarks and risk adjustment to be calculated and no minimum savings or loss rate before risk sharing starts. So the PRT was concerned that this may require a new risk adjustment and benchmarking methodology that needed to be developed specifically for the PAC-C model. PRT had concerns about the lack of confidence intervals around savings or loss thresholds. And so the model would share a higher proportion of savings or loss in the first 5 percentage points than it does after savings or losses exceed 5%. And the PRT was concerned about proposed risk-sharing asymmetry, which would favor favor savings over losses. On criteria 3, the payment methodology, PRT conclusion proposal does not meet the criterion. So many of the concerns for criterion 2 are really a function of the payment methodology and why the PRT finds the model also does not meet criterion 3. I've already highlighted these, some of the narrow dividing line between tier 1 and 2, the issues with confidence intervals, the payment methodology inversion. The PRT felt that there were similar issues around payment as there were with cost. Moving on to criterion 4, value over volume, notwithstanding the concerns, the PRT concluded that PAC-C's provision of care management payments to interdisciplinary palliative care teams has the potential to deliver high value care. For criterion 5, flexibility, PRT conclusion proposal meets the criterion for the reasons listed below. And in particular, the current fee-for-service schedule does not provide reimbursement for this type of care. In terms of criterion 6, ability to be evaluated, the PRT conclusion was the proposal meets the criterion. It again, the PRT noted that the model's goals are, in terms of the performance measures, are generally weak. However, as we discussed, some of the issues around potential enrollment bias, lack of confidence intervals, which I've already discussed, we really grappled with how well it can be evaluated, but ultimately concluded that it met this criterion minimally. For integration and care coordination, PRT conclusion was the proposal meets the criterion. And again, use of interdisciplinary palliative care teams will likely encourage greater integration and care coordination among practitioners. In terms of patient choice, the proposal emphasizes the process and provides limited evaluation of patient experience or patient-reported outcomes. That was certainly one of the concerns. However, in spite of the concerns as listed, the PRT concluded the proposed model would offer support of the unique needs and preferences of individual patients. For criterion 9, patient safety, PRT concluded proposal meets the criterion. The PRT has concerns about how the PCTs will work with the patient's primary care providers, but concluded the model's components that address care coordination aim to improve standards of patient safety. And then finally, for criterion 10, health information technology, the PRT conclusion was that the proposal meets the criterion. This one was not unanimous. HIT will be used to facilitate service delivery, et cetera. One PRT member concluded that this is insufficient to meet this criterion because the proposed model fundamentally requires information be shared across multiple providers in practice settings, but the proposal does not discuss if or how HIT will be used to accomplish this. In addition, there were some public comments as listed below, concerns about how HIT could potentially be used and were not included in the proposal, such as allowing patients access to their clinical health information, enabling patients and caregivers to track and share information with providers, as described below. So, in summary, the key issues identified by the PRT, some of them are described here. The PRT felt the model is overly complex, having multiple paths to eligibility with 2 tiers of eligibility and 2 different payment tracks. The proposed model's approach to quality assurance and measurement, including minimal standard for contact with beneficiaries, insufficient attention to patient outcomes, weaknesses in the period of time to be captured in the measures, and insufficient utilization measures, as described in Tier 1 and Tier 2. With respect to payment methodology, PRT's concerns are described below. The narrow dividing line between Tier 1 and Tier 2, the absence of confidence intervals around benchmarks, absence of minimum savings or loss rate before risk sharing starts, some of the methodology concerns I've described previously, and the asymmetry of the proposed risk sharing. With that, I'll turn it back to you.
Thank you, Paul. Any other comments from other members of the PRT? Yes.
Thank you, Mr. Chair. Paul did a great job sort of describing our report. I just wanted to underscore a couple of concerns that I had that were reflected, but I'd like to just sort of state them again. First, this is a high priority need area, and I think that the evidence shows the benefits of palliative care, so we do think this is a high priority area to address. But I think the lack of patient engagement reflected here, the lack of meaningful shared decision-making, I think it's a really important omission. And then also the lack of payment tied to outcomes. I personally think that the simply having a care plan or agreeing to monitor utilization without having any payment attached to performance is does not qualify as sort of what we are hoping to achieve. And then the asymmetry of the downside risk of 3%, upside of 20% just was also quite striking. And then finally, I was the holdout on criterion 10. I think the point of the HIT criteria is about enabling important information to be shared to enhance patient safety and outcomes, and I don't think we saw evidence of that.
Thank you, Elizabeth. Any other comments from the PRT? Before questions, then from the committee members. Tim, and then Bob, Kavita, and that.
So I wanted to thank the PRT for a very thorough and clear analysis. I did have a question on Elizabeth's last point that she made about the asymmetry and in the risk, upside and downside risk. And I wondered if you think of the infrastructure investment required to pull off any kind of care delivery as itself, in a sense, downside because it's your cost of operations. Did that figure into your thinking about the asymmetry? And I would just point out that there is actually an existing CMS model that has no downside risk, but gives credit to the participants for the fact that they had to make a large upfront investment in infrastructure as their downside risk. And I just, does thinking about it that way change the way you think about the symmetry or asymmetry in a risk arrangement?
I'm not sure that I can't remember if that point specifically came up. It's a good point. I think the blending of the per member per month, which was pretty large numbers, 650, in addition to this potential on total cost of care. I think we focus in my thinking that track one, where you are getting that upfront to recognize the investment. So I think it's a good point. I have to say I don't think we really had a discussion around that specifically.
Yeah, that's my recollection too. I don't think we discussed that specifically. I think we did certainly discuss the per member per month, and I think the sense of the PRT was that those per member per month payments were sufficient to cover the expenses, added expenses incurred, without distinguishing startup from ongoing expenses.
Bob?
Yeah, I've got two kinds of questions. The first is simple. The second will take a bit of time. The first is picking up on this. I looked up at the Medicare Care Choices model demo, and they were providing $400 and $200 of a PMPM, and this is significantly higher. So what confidence do you have that these numbers are the right numbers? They're 50% higher than what Medicare is paying for. It's not the same, but it's comparable.
One of our observations was that there wasn't supporting information for those numbers. That was one of our questions.
Okay. So here's my more serious question. I got a real problem with a total cost of care, shared savings, shared risk on a patient population with a high risk of dying, creating perverse incentives related to providing care. So my question is, did you look at, for the definition of the eligible population, is there a ballpark for the percentage of people who would be dead within 12 months, for example? Is that something that you'd looked into at all?
I think this gets back to our discussion, and we'll probably have it again, around the CTAC. We had this discussion when we had CTAC and, their initial proposal around how do you predict who's going to die in 12 months. And I think we continue to struggle with that. Again, a lot of the data is around cancer patients, and this proposal, and I think when we talk about CTAC later, it's a much broader, and we had a lot of concerns around particularly the criteria for the Dartmouth Atlas 3 chronic conditions. We could think of many Medicare patients that would fit that, and I'm not sure how easily it would be to predict how many will die within 12 months. So I think we discussed a lot of similar concerns around the predicting.
But how, I mean, did you discuss the appropriateness of a shared savings on total spending model for a population for whom dying is a real possibility? I mean, I could see doing this with track 1 using utilization metrics, inappropriate hospitalizations, all the questions, some of which are here about, you know, patient and family sense of interaction and responsiveness and all of that stuff. But when it comes down to a calculation of we saved a lot of money, and by the way, some people didn't get hospitalized who otherwise would have, and oh, and by the way, they died, that makes me nervous. And I'm wondering if the PRT had that discussion.
Yeah, I think we did, yes, I think it was reflected a little bit in the comments around the unintended consequences and then the interaction between the model and hospice in particular. So yes, we did discuss it.
But that didn't, except for some technical problems, you thought that the track 1 and 2 approaches were reasonable approaches to take in
well, you know, as we said, we didn't think it met criteria. And one of the concerns we had around that was unintended consequences broadly. And so I think what you're articulating is, again, one of the potential unintended consequences.
Okay, thank you.
I would say that we did discuss that concern, and it actually underscores the importance of better metrics and better measurement, better engagement, to really understand from the patient and family point of view, is care being appropriately delivered? So it really made those even more important.
You think that you can measure? I mean, I am very skeptical that you can measure that form of interaction with a patient to help them form a judgment about how they want their care provided over at the end of life. I mean, that's my basic problem. I don't think you measure that.
Well, it was simply another reason that we were concerned about the measures, but it did not overcome our concern about the incentives.
Bob, are you saying you can't measure it, or it wasn't measured here?
I'm saying I'd be very skeptical that you can measure it. As the palliative care team is interacting with the patient and their family and providing guidance around end-of-life decisions, I don't know how you measure whether the financial incentives are overwhelming their sort of neutral advice-giving. And so I have a real reluctance to thinking that we want to have strong financial incentives for this particular population. I'm all for total cost of care when somebody is taking care of general population. I have particular concerns about that strong spending incentive when it comes to a population who are very vulnerable near the end of life, I guess is what I'm saying. And I think as I've written and talked about, I think we have magical thinking around measurement. Some things you're not going to be able to easily measure. So I think this model could work without that spending incentive related to PMPM, utilization metrics, strike me as the right way to proceed in this area, not sort of total cost of care spending. That's redundant.
Thank you, Bob. Kavita?
I'll just reinforce, because I think that we're seeing so many PTAC models that feel the need to use kind of the CMMI playbook previously of some inclusion of shared savings or gain sharing, or even this kind of notion of total cost of care, which we're seeing problematic with the oncology care model, just as an example. So I would just say as a comment, it would be my desire to see some of those things, not saying that this submitter did that on purpose, but it just seems like I agree that this might not be the right way to incorporate what feels like is almost now just a kind of taken for granted submission. So that's not my question, but a statement. I did want to ask the PRT, I find that in taking care of these patients, it's extremely difficult to kind of engage in like a very, it's not the traditional metrics we have for engagement, so in a crude way in the system. So I wanted to just ask, because it looks like in your teleconference, you got into how complicated prognostication was and some of these other issues. Did you feel on the PRT that this potential for better engagement, whether it's of the patient or the caregiver, was really possible considering the severity of the illnesses that we're talking about? Because I just find it difficult to do. So that's one question. And then the second question is around a clarification. The PMPM would go into place kind of in 6-month aliquots, is that correct? So they would only reassess, there's a monthly kind of face-to-face or whatever requirement for the PCT, but then the prognostic changes that might occur would only be assessed at 6 months? So that's a clarifying question.
Do you remember, Ann? I'm trying to remember. I don't remember the 6 months. You mean in terms of reassessment if they go from Tier 1 to Tier 2?
Correct,
or that kind of thing?
or whatever, just
whatever
because this is, again, just in my clinical practice,
Right.
6 months is a long time for some of these conditions. So to kind of reassess their prognostication, if that's the way I'm reading it, but I could be reading it wrong.
I don't remember that, but I keep looking at Ann because she's...
No, I don't think the frequency with which people were reassessed to determine are you now a Tier 2 rather than a Tier 1 was specified. But I don't believe so.
Sorry, to your first question, I want to make sure I understand your first question.
Do you really think patients can engage? I'm asking, like, is there was this a kind of a general, because it was one of your, like, real strong shortcomings, or at least that's how I heard it. Do you, and what would patient engagement, when, I mean, I just had a patient die of, like, cancer, and engagement in some of these settings is difficult. And I also don't know how to measure that in a way that I can reproduce. So I'm just curious.
Yeah, I mean, I think that's reflected in our concerns around how do you measure that? You know, can they be engaged? I mean, potentially, but how are we going to measure that? And I guess that gets to both your point and Bob's point around, is that really measurable in a meaningful way in this kind of model?
Just my last, Jeff.
By the way, they are assessed every 6 months.
That's what I thought. Okay, so there is a reassessment, but it's only every 6 months. Okay, and then just the last one, did attribution come up in terms of, there's this attribution where if you're on the PCT team, you can't do like CCM, or you kind of get carved out of other things, but I would see potentially methodologically that's not part of our criteria, but I was just curious because I could see attribution being a pretty kind of complex issue. So I just wondered if that came up on the PRT discussion.
I don't think we had a lot of discussion on attribution in terms of thinking that once the PCT is formed, and that I don't remember having a lot of discussion around that.
I think attribution at this point is the team, the palliative care team, as opposed to any individual member of the team or other physician, is my recollection.
Lynn.
So a couple questions. Picking up on Bob's question, which was one of mine, how many people are likely to die that are in this circumstance? And apparently you didn't know or can't find out. And what I really want to know is how much money is attached to them compared to the rest. And I assume SSS wasn't asked that either. So what I'm just going to say as an economist is one needs to think about the right benchmark here. And certainly I get the untoward nature of an incentive where people could die and save money, but if you compare spending on people who died in the program versus people who died outside the program, you can construct a benchmark that might be useful. So it just has a matter of how you define what the right benchmark is. I'm not saying they defined it correctly. I'm just saying it's not impossible to me to imagine a world in which we get the right comparison group to do this. Which gets to the larger point about what I'm hearing, and I'm just a simple country economist, so I don't know this doctor stuff, but I'll observe what y'all are saying is it's impossible to measure quality for these people. I don't think that's true. I think the people who do this for a living know a lot about that. And what I want to ask is, when I look at their table 3, and I see a lot of stuff, you know, patient's perceptions, obviously family perceptions in some circumstances, timeliness of response to urgent need, adequate treatment for pain and symptoms, likelihood to recommend a PCT to friends or family. In the first couple of years, it's pay for reporting, which I agree is soft, but then it gets to pay for performance. And my question really comes down to, did you take into account the learning that's going to have to happen in this space when you decided these quality metrics weren't good enough? And that's really what killed the payment model as well. So that's my question. Can we not learn while we play the game?
Yeah, I think our concern is that there's, in terms of the quality measures, that they were not sufficient to, again, particularly around, you know, process versus outcomes in this very, you know, chronically ill population.
But the ones I'm citing are patient-reported outcomes, which in the first couple of years is pay for reporting, and in years 3 or 4 would be pay for performance. So that would seem to me to be outcome-based, patient-centric, and actually incentivized in years 3 and 4, not years 1 and 2, but we all agree there's some fuzziness.
Yeah, I guess part of it was, you know, when those were going to be assessed and how often the requirements around the assessment. It seemed that the minimal wasn't sufficient in terms of the number of times that would be assessed throughout their care as well.
I'm going to just, I saw Bob, did you want to respond to Lynn's? Yeah.
Just wanted to be clear, I actually think in this area you can develop quality metrics and you can develop utilization metrics, so you could have a payment model that does not require total cost of care and spending incentives, but rather there are ways to actually, on top of a PMPM, you can actually measure performance and build in protections there that you can't build in when it's just a total cost of care analysis.
Yeah, I think the PRT agree with that. It wasn't that, so we felt it could be much stronger.
Grace?
Was wanting to respond a little bit to Bob's remark about his anxiety or concern about strong financial incentives in this population. Well, I think the reason we exist is because there's already strong financial incentives in our current situation with mostly fee-for-service that people are concerned about. And so as opposed to this being greenfield, where we're looking at it as, you know, everything is perfect and now we've got something that we've got to react to, we're not looking at greenfield. We're comparing it to something that's already out there. And there's been a lot of measures out there, a lot of studies, a lot of mythology that, you know, X% of the cost of Medicare is in the last year of life, and then some of that's been deconstructed subsequently and shown that, well, maybe it's not the case or maybe it is the case. So one place perhaps this could be strengthened would be to understand what has been learned from studying this population in the fee-for-service system with respect to the perverse incentives that we're all concerned about with that. So with that thought process, when I look at this, it's a classic example of when you separate out the payment model from the care model and you look at the care model, you're thinking, of course everybody wants that. I was experiencing in my own family this weekend a call from a cousin of mine who's very anxious about a situation that was 3 of those categories and criteria with someone in my own family, and they did not have the care model that is in this that would have solved a lot for them. So my thought process is that as we're thinking about this type of model, many of the others that I think we're going to be looking at today that are similar in terms of taking care of vulnerable, complex patients and trying to come up with a payment model that properly incentivizes so that we don't do it wrong, we don't do it right. We need to think about the payment model, which there seems to be enthusiasm, the care model, which there seems to be universal enthusiasm for, and then look at the payment model, not just in terms of it in and of itself against greenfield, but what are the actual perverse incentives now and what data is out there that can allow us to think through it within the context of the complexity of real time.
So just to, and I think those comments are well said. And, I think when you get to the data part, and I think we've talked about this before, where the prognostication around, there's data particularly around the stage 4 cancer patients, and now we're trying to expand it to other, very, severe conditions like heart failure, et cetera, where it's not as easily predictable. And then I think, so the challenge around the payment becomes that, but not that they shouldn't, I think we'd all agree that there's a clinical need for sure, but how do you construct a payment model around sort of much broader conditions?
Thank you for that discussion. I am now going to invite the submitters up to the table. If you could please come up and turn your placards right side up and then introduce yourself. I want to remind the submitters we have 10 minutes for your remarks, and then the committee will ask questions. Welcome.
Good morning. I'm Arif Kamal, I'm a medical oncologist and palliative care physician at Duke University, member of the board of directors of the American Academy of Hospice and Palliative Medicine, and immediate past chair of the Quality of Care Council for the American Society of Clinical Oncology.
I'm Joe Rotella, Chief Medical Officer for the Academy, and I bring to our team my early career experience as a rural primary care physician in New Hampshire and 2 decades as a palliative care specialist and hospice medical director. I'm a co-author of Measuring What Matters and a consultant to a CMS contractor working on the hospice quality reporting program.
Good morning. My name is Janet Bull. I'm the Chief Medical Officer of Four Seasons Compassion for Life, a nonprofit hospice and palliative care organization in Hendersonville, North Carolina. I'm also the immediate past president of the American Academy of Hospice and Palliative Medicine, and I co-chair the Global Palliative Care Quality Alliance, one of 2 clinical data registries for palliative care.
I'm Phil Rogers, and I practice palliative medicine and family medicine at the University of Michigan, where I direct our adult palliative medicine program. I have also been honored to serve as a volunteer chair for AAHPM's Alternative Payment Model Task Force, which designed and drafted the proposal under consideration today.
Welcome.
Hi, I'm Jackie Kosinski. I serve as the Director of Health Policy and Government Relations for AAHPM.
Hi, I'm Cindy Moon. I'm Vice President of Healthcare Payment and Delivery Reform at Heart Health Strategies, and we're a consultant to AAHPM.
Welcome.
Good morning, and thank you for the opportunity to come before you today to discuss AAHPM's proposal for a physician-focused payment model, which we call Patient and Caregiver Support for Serious Illness, or PACSI. AAHPM is the professional organization for physicians specializing in hospice and palliative medicine. Our more than 5,000 members also include nursing, social work, and spiritual care professionals who are deeply committed to improving the quality of care and the quality of life for patients living with serious illness and their caregivers. Numerous research studies demonstrate that high-quality interdisciplinary palliative care can provide significant benefits for patients, caregivers, and payers. Despite these proven benefits, however, many do not receive palliative care because current payment systems do not provide adequate support to deliver palliative care services where patients want them most, which is where they live. AAHPM developed PACSI to overcome these barriers and create an accountable payment system to deliver community-based palliative care to high-need patients who are not yet eligible or ready to elect hospice care. Members of our task force represent the diversity of palliative care providers serving Medicare beneficiaries today across communities of all types. We charged ourselves with developing a payment model that would support palliative care teams of different sizes, organizational structures, and geographies in the delivery of effective, high-valuable care to our sickest, most vulnerable patients and their caregivers. We look forward to discussing that proposal in detail with you today. Before we move into that discussion, we think it would be valuable to share the guiding principles that we used to develop PACSI. These include the following. Payment model design should both increase access to and ensure sustainability of high-quality palliative care and hospice services. Patient eligibility should be based on patient and caregiver need, not on prognosis. Provider eligibility should encourage participation by palliative care teams of many sizes and types, working in many different geographies and markets, and at various levels of risk readiness. Palliative care team structure and service requirements should align with the National Consensus Project clinical practice guidelines for quality palliative care. Quality measurement and accountability should align with a state-of-the-field framework known as Measuring What Matters, an expert consensus project convened by AAHPM and the Hospice and Palliative Nurses Association. This framework is in wide use among community-based palliative care providers and has a maturing evidence base to support its validity and its impact on care quality. Payment should be sufficient to cover the cost of delivering care in diverse settings, including rural and urban underserved communities, without increasing net costs to the Medicare program. Payment benchmarks should be accurately risk adjusted to avoid exaggerating losses or gains. And finally, the APM development process should be transparent and inclusive and engage the breadth of stakeholders in the serious illness provider community to address cross-cutting high-priority concerns. We remain as committed to these guiding principles today as we did when we began model development.
We started our palliative care program in 2003 as a way to meet the needs of the seriously ill people who live in our community. Far too often, we were seeing people referred late to hospice care, never having a discussion about what was important to them or how they wanted to live out the last phase of their life. We saw a fragmented healthcare system where families and patients struggled to get support, where they had misunderstandings of the severity of their illness, and where their suffering was not being addressed. We knew that the only way to provide high-quality palliative care was through philanthropy and grant dollars. In 2014, our organization received the CMS Innovation Grant to demonstrate the value of community-based palliative care. Over the course of the next 3 years, we scaled the model throughout Western North Carolina and upstate South Carolina, working with hospitals, healthcare system, and community-based hospice and palliative care organizations to create a longitudinal delivery model, integrating interdisciplinary palliative care across inpatient and outpatient care settings. This program addresses the needs of people with serious illness through goal-concordant care, advanced care planning, symptom management, prognostication, psychosocial and spiritual support, patient and family education, and caregiver support. We enrolled 5,800 participants and were able to demonstrate improved symptom management, decreased hospitalization, increased hospice utilization and length of stay, and high patient, family, and provider satisfaction scores. The grant allowed us the flexibility to meet the needs of the individual patient. For instance, in rural areas where workforce shortage and response times lag, we piloted a telehealth project where combined remote patient symptom monitoring and video conferencing were used. As a result, more timely interventions occurred and problems could be managed preemptively, often avoiding emergency room visits or hospitalizations. There are currently few palliative care programs in rural areas. Creating an APM where small organization participates aligns with our guiding principle of being able to provide access to palliative care regardless of where people live. One of the charges of this grant was to come up with an alternative payment mechanism. Our team collaborated with the Academy's APM task force, and we were able to take what we learned in this project to help inform the PACSI model. Under fee-for-service reimbursement, community-based palliative care is not sustainable. Today, these programs exist only through community donations, grant support, or being subsidized through a healthcare entity. A value-based payment system will help create a sustainable model aligning with another one of our core principles. It is my hope that all people living with serious illness will have access to high-quality palliative care where treatment is informed by a person's values and preferences, where the focus is on improving symptoms and enhancing quality of life, and where suffering is addressed in the physical, psychosocial, and spiritual domains. Participating organizations of an APM should be held accountable to quality, cost of care, and patient experience of care. Thank you.
As Dr. Rogers mentioned, our guiding principles for quality are to ensure sustainability of high-quality palliative care and hospice services and align with the state of the field. Even more, to deliver outcomes and an experience of care that truly transforms the quality of life for people living with serious illness and those who care for them. We acknowledge gaps in the development and implementation of quality measures for this population. PTAC advances quality improvement and accountability while building on the best tools now in use in hospice and palliative medicine, including Measuring What Matters, the Hospice Item Set, and the Hospice CAP Survey. These are evidence-based, tested, and proven to be feasible, actionable, and meaningful. Our process measures are based on the key elements of a comprehensive assessment as outlined by the National Consensus Project's Clinical Practice Guidelines for Quality Palliative Care. The patient and caregiver surveys are administered after admission and again after death, and domains include help with pain and symptoms, multiple symptoms including shortness of breath, constipation, sadness, and anxiety, timeliness of care, quality of communication, support for spiritual and religious beliefs, respect for the patient and family, overall satisfaction with care, and also a shared decision-making domain that gets at whether they were able to make a decision without feeling pressured by the healthcare team. We were parsimonious in selecting utilization measures for accountability. We picked the ones that matter most and we have the most impact on, but others are included in program evaluation and would be reflected in the costs. Palliative care is whole person care delivered by an interdisciplinary team, not limited to symptom management and physical outcomes. And that means that the patient and caregiver experience items in the surveys reflect more than mere satisfaction and are actually key outcomes of palliative care. We're mindful of the burdens to vulnerable patients and stretched caregivers were we to survey them too frequently, and also challenges that might discourage smaller practices from participating were we to mandate the use of quality instruments that don't reflect current practice. Where measures have not yet been developed, tested, and implemented for this population, we require pay-for-reporting in the first 2 years before setting a benchmark for pay-for-performance in year 3 and beyond. We built accountability for quality into every aspect of our model. We appreciate this opportunity to present this proposal on behalf of the sickest and most vulnerable patients in our healthcare system. We know that there are some aspects of the model that can only be refined once CMMI engages in development of a demonstration. In the 7 months since we submitted PTAC to you, more evidence has been published. New data sets are available for analysis. New quality instruments and measures have begun development. And the National Consensus Project Clinical Practice Guidelines are getting a major update. Knowledge and resources for quality and paying for value are rapidly evolving, and that's great. We're committed to working with CMS and all stakeholders to find the best solutions for our seriously ill patients and those who care for them. And it's urgent that we start now. They're counting on us. We thank you for your careful review. Your feedback is extremely valuable, and we urge you to recommend PTAC to the Secretary for a national demonstration. Thank you.
Thank you. I now open it up to my committee members. Bob?
Well, yeah, to continue where I was earlier, I didn't hear in Dr. Rogers, your principles, any mention of one of the principles should be to reduce total spending for this vulnerable population. If anything, you emphasize the need to pay for the costs of high-quality palliative care. So where does the, I guess, here's the question, couldn't this work without the strong financial incentives around spending reductions? I agree with the development of measurement sets, pay for performance, paying adequately for the care in the first place. Why do you need to have these spending incentives, and to what extent was trying to become an advanced APM a contributing factor in what this looks like?
Excellent questions all, and I appreciate your pointing them out. I will say that when I did articulate the key principle about adequately paying for the service, I apologize if I was speaking too quickly, but baked into that principle is a balance that should not add to the net cost to Medicare. We actually we agree with your concern that we should not rely on savings for in this vulnerable population. We did include that in the design for two reasons. The first is that there is abundant evidence that we've cited and included in the proposal that when we do palliative care right, it does save money. And it saves money primarily by aligning care plans with what matters most to patients when they're at their sickest. And that often means not engaging in low-value care. So that is a reality. There's data about palliative care in hospital settings saving money. There's emerging data about palliative care in the community saving money. I will say that in model design, particularly in Track 2, we were intending to have Track 2 meet the criteria for an advanced APM as outlined in the statute. And as Dr. Patel pointed out, like many, we did look to the shared savings methodology from CMMI's playbook. I would also echo Mr. Nichols' comment that we would very much like to work with CMMI to get to a place where we could use spending benchmarks to be able to set the performance standards on spending to ensure that we hold not only to our guiding principles of improving care quality without increasing cost, but also meet the statutory requirements in MACRA.
Grace?
I was really interested in the North Carolina data that you had, being a North Carolinian and living in that area with respect to the 5,500 individuals. And I got a couple of questions related to that. And was the data with respect to the cost of care and what you were able to save with all the overall hospitalizations and all that directly tied back in any way to the numbers that you put in this proposal? Because it would seem to me that for 5,500 people, if you've got good data, if this is similar to the model that you have here, you've certainly in a grants-based project have cost of implementation of that. Was that actually tied back to the numbers in this proposal?
So actually the cost of delivering the care was informed the two different tiers that you see in this model. And it was not only based on our data, but some of the other members of our stakeholder of the Academy's task force. In terms of the savings costs, we unfortunately did not get all of the claims data until about 2 months ago. So we are still going through that, our team at Duke, but we have shown a reduction in hospitalizations. I don't have the final number yet, but that was clear, and in ED visits.
So you believe after you have those final numbers, we will have some hard data from which we could actually look at this and other projects and make a determination with respect to what numbers you have in here?
I think it will definitely help inform the project. There is also other data that's out there. Dana Bader, who's going to be commenting today, ran a model at ProHealth, and they published on their overall cost of savings. So there have been some other publications out there around cost. But the way we based the cost on this was what it cost to deliver this care.
Okay. So my next question is somewhat related, and that is, one of the other PTAC members expressed a concern about the potential perverse incentives of having a tiering of complexity. Obviously, this is now baked into any sort of tiering system based on how ill a person is. And that will therefore lead to other types of measures where you have to prove they're that sick and all of that. So as you made the decision to do that, what I just heard you say is that you were using those type of criteria in a program that probably wasn't based on actual an incentive at the time to if you will, upcode severity, right? I mean, it was to identify what their needs were.
It was to identify what their needs, but as people got sicker, we had a priority, risk stratification system we developed. So as people got sicker and their functional scores declined, they required more help, they required more visits. So the cost of care in that population was higher.
But so if every 6 months you're reevaluating, people tend to get sicker in this population. So is there a reverse incentive, if you will, to look at it again? In other words, is there not, what would be the difference between doing it this way, where you've kind of broken down the cost into two different categories that may create a perverse incentive versus having a blended rate that would take care of everybody? Tell me why you chose to do it this way. Any of you? I'm staring at you. But
So I would say, just to echo Janet's point, we started this based on the cost of what it takes to deliver care to patients, especially as they get sicker. I will say many of us in the palliative care and hospice world have a lot of experience with a PMPM or a capitated rate, because that's how the hospice benefit is structured. So we've gotten 30 years of experience of delivering high quality care to very seriously ill patients in the community. If you think about the hospice per diem and convert that to a PMPM, that's about a $4,000 PMPM. So we realize that these numbers may look high coming at it from a traditional Part A, Part B perspective, but we're accounting for the fact that many of the patients in the model are those who may be nearing hospice eligibility, but may not be yet ready to enroll or right there. So that higher number accounts for the increased intensity of services to deliver on the quality accountability that we've built in to the model. To your point about a blended rate, we talked about that because we actually accept the PRT's observation that there is complexity in this model with the tiers and the tracks. Part of why we didn't feel like we could get to a blended rate with confidence is we don't yet have the data. Community-based palliative care is in its, if not infancy, in its early childhood. As a family doc, I'll use that word. And really, we need to inform this model with data. We are very open to working with CMS to understand from the data that they may have that we don't have access to what that might look like. But this was based on the experience we have on what we were able to put together in August of 2017 when we submitted. As Joe mentioned, we're getting more information and data all the time. Janet's CMMI project is an excellent example of that. And we're in this for the long haul, and we're willing to work however we can to make it viable.
And one point I just wanted to clarify, the recertification was put in there because there are occasionally people who actually get better. And it wasn't meant that if somebody came into the model and in a month started to have significant decline, they could go into the second tier. There wasn't a waiting to be looked at every 6 months to determine what level that the patient fell into.
Tim?
Thanks for all your work on this. So I have a question that, and maybe it's best to think of it in more abstract terms, about when you were thinking about this model and the composition of the care team and the qualifications of the people on the care team. And I ask you to respond thinking about the fact that, at least from my perspective, we almost certainly don't know what the best mix of people to take care of these patients is. And I'll just say, I'm right now the ward attending at Mass General. I rounded yesterday. Half of the 30 patients on the floor that I'm attending on would qualify for this model today. And I would tell you, reading this and thinking about their care, they would all benefit enormously from what you're proposing. So I want you to answer knowing that I feel that way. But I'm also pretty sure that the healthcare delivery system needs to be open to the possibility that there are going to be entirely new job descriptions and roles, and that overly prescriptive requirements for participation for particular role groups and particular qualifications, I would say potentially stifles innovation. Could you reflect on your proposal and those general comments, which I think probably weren't too cryptic to understand?
So we absolutely appreciate that. And we did conceive, again, one of our guiding principles is that this model be able to be engaged by providers of all types working in all communities. And one of the reasons why we put in the certification requirements for one of the members of the team is we did not believe that we wanted to be overly prescriptive and say, for example, the physician on the team had to be board certified in hospice and palliative medicine. Not only is that a problem because of the workforce issues that we have in our subspecialty field, but it's also not the right thing for patients and families. If a patient is a family, I come to the table with a hat of a family doc as well, and my practice tends to skew towards a more complex, older population, I would see colleagues of mine who I know who are very skilled, have long relationships with their patients, want to engage this, and if we could provide their practices the opportunity to build out a team that would allow them to extend their reach into the home, I think that would be a model that would be allowed under this. So I would see flexibility. We did feel, though, just because one of our good guidelines, especially at this critical time of development in the field, is that we strive for high-quality care that's aligned with the state of the field, and not only with Measuring What Matters, but with also the National Consensus Project, which sets the stage for what it means to get high-quality palliative care, that we needed to have some infrastructure there to ensure that. And when we get to talk a little bit more about the quality metrics, that's where we're putting in the accountability for that care. And the results of this demonstration, our hope is, in the long run, informed better benefit development, and that may look different than this. We're very open to that idea. But really what we want to achieve is providing a vehicle to extend that support where it's needed most. And we think some degree of flexibility while also retaining some guardrails around quality.
Thank you. Elizabeth.
Thank you. And again, I wanted to just underscore the PRT's support for this and the need for this change. It's just, I had a question, I think Grace asked it as well, sort of the basis for the numbers, and I think you said it was the cost of delivering care. Is there anything you'd wanted to add to that? Because there were questions from the PRT about how we got to those rates.
So I will say that we did provide in an appendix to our proposal an analysis of Medicare fee-for-service data crosswalked with NHATS responses that are kind of a way to get at patient function. And the idea there was to start getting an estimate from the data that were available to us by one of our colleagues, Amy Kelly at Mount Sinai, who does excellent work in this field, to try to get at what is the cost of care, and to sort of begin to say, could we look at a way to make sure that we align again with our guiding principle of cost neutrality and the statutory requirement. And that did inform part of how we came to those numbers. We understand that our view of that data is incomplete because we have access to only so much in terms of claims data, but we wanted to show that as kind of an early proof of concept. In that same appendix, we were also able to work with colleagues who are doing this kind of work in other venues. So you'll notice Janet's data in that appendix from the CMMI group. We're also very pleased to have collaboration from the team at Aspire Health, who has gotten a lot of experience working with the Medicare Advantage plans. And as you're all aware, Medicare Advantage plans have much more nimble access to claims data than we do on the traditional side. So we're trying to show that we're moving in the direction of setting those price points, not only where we can support the kind of quality care that we know beneficiaries deserve, but can also do it with a goal of at least cost neutrality, if not some modest cost savings.
I actually wanted to underscore something publicly, maybe for the comments, that also sort of the catch-22 of this, where we need benchmarks, but we can't establish benchmarks, or we can't establish some of the information needed without some form of testing. So I just wanted to underscore that for our comments. And then finally, could you speak at all to the initial 2 years of pay for reporting versus paying for outcomes, and sort of address that issue?
This gets back at our principle of wanting to build on the current reality. So we know that there are great gaps right now in having a really robust measure set for people with serious illness. We're closing that gap as fast as we can, and in fact the Academy is involved in a number of initiatives in measure development, bringing quality registries together where we can then really vault forward with patient-reported outcomes and that sort of thing. The measures we're bringing to you come from hospice populations, inpatient palliative care populations. They have not actually necessarily been validated, tested in the community-based palliative care population. If we're going to be scientific about that, we should actually test those and validate them before we set benchmarks. So the reality is pay for reporting in year 1 and 2, because we actually have to learn as we go along. This is the same thing we saw with the hospice quality reporting program, where the first few years were pay for reporting, because until the reporting occurred, nobody could figure out exactly what was topped out, what's a decent minimum performance status, what's the right benchmark. So we're just being honest with you. Current reality is if you want to wait for the quality to catch up, we're going to be delaying testing a model that's really needed right now.
Thank you. I have a question about the interface between the program and the patient. As I understand it, there's a survey, the patients are surveyed at the time of admission into the program, and then there's another follow-up with the family members at the time of death. Do I have that right? Yes. So this is I think there have been comments about this is a learning process. I heard the word demonstration. I heard the word, we don't have all the data. We need to, for us to sharpen this model, which I completely agree is incredibly important to the patients who need it the most. And I applaud your efforts, and particularly driving this into communities where there aren't organized systems of care, and those patients desperately need this kind of support and compassion. My question is, if we really want to learn and try and sharpen the program, asking folks, getting the members or the patient's perspective at the beginning, at the signing up, and we understand that there's a deterioration, obviously, of their condition, how they interact, their needs change in flight. I just want to understand why we wouldn't want to lean in and acquire additional input as the program plays out. I understand the family's perspective at the end is very, very important, but it seems to me there's a lost opportunity, and I'd like to know your thinking about that. Thank you.
Sure, thank you for that. So the balancing act in surveying patients and their caregivers more often is that because we're trying to gather actually quite a few outcomes and experience items, there can be a burden to taking the survey. So we are sensitive to the fact that we don't want to do it more frequently than necessary. The current hospice quality reporting program, there's really only one point in time when the survey is done, and it's after death. We've added, in this case, something after admission. And we would be quite open to having more frequent surveys, for example, something like every 6 months while under service. But what we have to be careful we do is that we don't over-survey this vulnerable population. I'm picking up on, I think Dr. Patel was suggesting that, this is a vulnerable population that we have to consider the burdens. When you think about the process measures that come from measuring what matters, which have been used some in the field, I think those could be gathered more often. What we have to think about there is that some of the smaller practices that are just ramping up to do this service, which we'd like to include in the model, we don't want to overburden them by doing it more often than is really necessary to build the database. So I accept your concern that we might learn faster if we could gather more data points more often. And as long as we're balancing that against the potential burden and discouragement of smaller practices from joining or overburdening our families and their stretched caregivers, I think that's worth considering.
Right. And again, just to punctuate my point, it seems like there should be one set of input from the actual patient, aside from when they sign up, on how the program is, how we're doing, I guess, to allow the program to make adjustments and to learn. And it just seems like there's a lost opportunity. So thank you for that. Rhonda?
I don't know if Paul, I think, was next. No, I just simply wanted to say thank you for bringing to us a proposal that addresses a whole person and their family. I want to thank you for actually speaking to the overwhelming need to expand this to a larger portion of our population. I think what you hear are questions more about process more than I don't think there's a concern about support or any difficulties with understanding the need to doing this in a better way. When you guys were talking and I heard some of the questions, I initially thought that you were already part of an innovation grant, but you are not, correct? You are.
Just my organization.
Part of you is. Okay.
Yes, part of us.
Okay. And so CMS has already had an opportunity to work with you. They obviously thought this was a worthy concept, at least the proposal that you put forward.
Correct.
And they are evaluating a payment model, but not necessarily this payment model. So there is already work underway to review and hopefully to consider expansion. Is that correct?
So part of the charge in round 2 of the innovations was to come up with an alternative payment model. So we were working with our colleagues at Duke, who are the co-principal investigators. And as we started model development in that particular arena, I was also involved as president of the American Academy and was on that task force. And it made sense as we went forward to put those two together.
So is that what this is coming
So
together?
this is really
This is another one.
No. This is the PAXI model. It helped inform the PAXI model.
Okay.
This model is from the Academy. It is informed by some of our work at CMMI.
No, I'd like to see something move. So I'm just asking how many paths are going.
Yeah, we're doing our very best to coordinate work together, and I think what we're learning from Janet's model, even as we're just getting the claims data, has been, will be very helpful in understanding this. But even in the experience with understanding cost of care in an organization we're working in one of our priority communities, which is Western North Carolina and upstate South Carolina, which is a rural area, has specific challenges. We, however, will want to make sure that we're broad to make sure the model is applicable across all communities, more densely populated suburban, urban areas, and just because all beneficiaries deserve this service regardless of zip code. So we're broadening out the kind of composition of this, and we are bringing one proposal together.
Thank you.
Paul, I apologize for getting out of sequence, too.
That's okay. You would have left Rhonda's nice.
I know. When
that would
Rhonda
have been a nice
speaks,
way to,
it's like, we listen. So
sorry.
I couldn't help myself.
It's okay. Underscoring clearly, I think you're hearing we all recognize the need, and I think that's reflected in the PRT's vote on the scope, that it meets criteria and deserves priority consideration. So I don't think there's really any question there. Just two specific questions. And again, in talking to our palliative and hospice care expert and the discussions we had there, these are two areas. One was the certification. So it could be physician, nurse practitioner, social worker, spiritual care provider. And again, this is maybe, I have certainly a much better understanding around the physician NP certification. I don't have so much around social worker, spiritual care. And I understand the flexibility is important, but I guess it just raised the concern, could you, and I'm not picking on the spiritual care provider, but I just don't know their certification. if they're the certified one, and then you have others who may or may not have the background. So it was brought up by the expert, and just wondered if you had that discussion. And then the second has to do this tier 1, tier 2 jump, and the comment from the expert around, well, the palliative performance scale can fluctuate quite a bit, so going from 60% to 50% may occur not infrequently. And then the comment from the expert that the utilization criteria, particularly moving into tier 2, was a little light. So again, you probably had discussions, because again, this dichotomy versus, you know, sort of a continuum, and so how you got to those.
So, I'll speak to those in order if I can, and maybe hand off the last part to my colleagues. So speaking first to the certification, kind of echoing back to Dr. Ferris's comment, we want flexibility in the model. I will say we've had a lot of discussion about kind of how to balance that against ensuring the fidelity of the intervention. Specifically to spiritual care, there is no current specialty certification in spiritual care for palliative care. There are professional chaplains who go through a certification process. So there is subspecialty certification for physicians, nurses, and social workers. So, you know, so that's one piece, and that's meant, again, to allow this to be applied in a wide variety of settings. Where we hope to be able to ensure the fidelity of our intervention is on the quality accountability side. So we ensure that there's accountability for quality throughout the model, and that's how we want to kind of get to that piece. To the kind of tiering, you know, again, I won't reiterate our earlier comments. The tiers were meant to reflect the clinical reality that patient intensity increases as they get sicker. And we absolutely understand that any clinical assessment, whether it's for function or prognosis, is subject to significant judgment. We actually have some harder data and stronger evidence base for function. So that's why we chose that over a prognosis model. Also tying back to what many of us deeply believe in one of our guiding principles is that patient eligibility and enrollment needs to rely on patient need, not how long we think they have to live, because frankly we're not that good at it. And you know, even if we were, patients may have a short prognosis without significant need, and they may have significant need without a prognosis that we can determine. So really, when we get down to trying to meet unmet needs and reduce suffering of patients, families, and caregivers, that kind of patient-facing stature. And I'm going to respectfully ask you to repeat the last question because I just forgot it. I apologize.
No. It was just around the utilization piece again, with criteria
Great.
1, 2, and you know the expert sort of said, well, it seemed a little light.
Yeah, thank you. Again, from the modeling that we have, that you'll see in Appendix 5. I apologize. The patient data, we use that utilization to try to, with the data that were available to us, to identify patients who had enough opportunity with respect to reducing avoidable spending to keep the model cost neutral. Patients are expensive in the hospital. We know that. That's where we tend to spend money. Sick patients are very expensive in the hospital. So we do have a more stringent utilization threshold for tier 2 than tier 1, which includes a hospitalization and at least one other unplanned contact with the system. So ED visit, observation stay, second hospitalization. And what those tend to mark in our clinical experience, and I'm sure many of yours who face patients, is that when patients come to an ED or get admitted, it's a sign of an unmet need. Either because their disease has progressed to a place where the family can no longer take care of them, caregiving is broken down, all kinds of reasons. So that's why we did have a stricter criteria for tier 2.
Seeing no other questions, I want to thank all of you for your hard work and coming here today and the comments. We're going to move with our process. So again, I thank you for your efforts. But we're going to go ahead and open it up for public comment now. We have quite a few folks who want to make public comments, and in order to allow for everyone to get their time, I really do want to hold folks to 3 minutes. We've been fairly gracious in the past, but because of the number of people who want to make comments, we're going to try and stick to the 3 minutes. I'd just like folks to be mindful of that. We're going to go ahead and start with Sandy Marks from the American Medical Association. Hi, Sandy.
Hi, thank you. We commend the PRT for its careful review of this proposal, also the other committee members' comments, and your efforts to identify the strengths and weaknesses. I think for APMs to be successful, they need to be designed well, and there's really nowhere that physician practices or specialty societies can go today for technical assistance developing good payment models. That's why the AMA successfully urged Congress to clarify the macro law last month. The comments, suggestions, and feedback from the PTAC on proposals are very helpful to those who are developing APMs. But just because there are areas where improvements are needed in a proposal does not mean the proposal fails to meet the criteria. The PTAC has reviewed other proposals that it recommended for testing, even though they needed some improvements. In the AMA's comments on the CMS Innovation Center's new direction last fall, we said it is impossible for physicians to accurately determine the costs or outcomes of a new approach to care delivery without actually implementing it, that this requires having a payment model that will support the new approach, and that CMS should assume that every APM will need refinement, and that goes for the PTAC as well. In terms of the quality and cost criterion, this APM is designed to support services that are really not available to Medicare patients today. It doesn't seem reasonable to us to expect a proposal for something new like this to already have experience with outcome measures and performance standards. In fact, when CMS created the comprehensive joint replacement model, it provided additional payments to participants that were willing to collect outcome measures for joint replacements. The PRT also expressed concern that the proposed model might not improve health care at no additional cost. But couldn't that be said about every APM that is tested? If the PTAC requires proposals to guarantee savings or quality improvement before it will recommend that they be tested, it will be very hard to make progress. It should be possible to pilot test models and then make changes as people get more experience with them. That's why there are so many different ACO tracks, medical home models, and bundled payment initiatives right now. Current Medicare spending is very high on patients with advanced disease, and it is impossible for patients' caregivers to coordinate everything themselves and keep people from getting unnecessary tests, procedures, consultations, medications, and emergency visits, because today no one is really accountable, and too often there is no real team. It is difficult to imagine that this APM would not both save money and improve the quality of life for patients. Thank you.
Thank you. Next is Diane Meyer from the National Coalition for Hospice and Palliative Care.
Thank you very much for the opportunity to address you. My name is Diane Meyer. I'm a professor of geriatrics and palliative medicine at the Mount Sinai School of Medicine and director of the Center to Advance Palliative Care. However, today it is my pleasure to be here as the president of the National Coalition for Hospice and Palliative Care. The coalition represents 10 leading professional national organizations dedicated to the provision of high-quality palliative and hospice care. Our organizations represent more than 5,000 doctors, 1,000 PAs, 11,000 nurses, 5,000 chaplains, 7,000 social workers, researchers, pharmacists, along with over 1,800 palliative care teams and 5,300 hospice programs. Together, we care for millions of seriously ill patients and families every year. Our coalition strongly supports the model outlined in PTAC. Specifically, we want to comment on 4 key provisions. The first is that the model should be based on the consensus established palliative care quality guidelines that were earlier mentioned. These guidelines have been in place since 2004, are evidence-based, and reflect expert consensus on the key elements, and must therefore serve as the platform or the standard for the design of any payment and delivery model. The second is that the team composition, that the interdisciplinary team is indeed essential. The quality guidelines underscore this. Each team member addresses the distinct and diverse aspects of care needed by people living with a serious illness, as well as those of their family and other caregivers. Research demonstrates that palliative care delivered by such a team improves quality of life, quality of care, and by averting preventable crises, reduces costs. Importantly, and this differs somewhat from what you heard before, the coalition recommends that at least one team member who is a prescribing clinician with board certification. We are concerned that without this certification, beneficiaries are at risk of poor quality care, including, and very importantly, poor prescribing of opioid analgesics. Most clinicians have had no training in how to do that safely. Eligible entities is our third point. We encourage PTAC to recommend the widest possible range of qualified entities be eligible to participate, thus serving the broadest possible group of beneficiaries and caregivers. This would include teams working as independent practices associated with hospices, home health organizations, hospitals, health systems in urban, suburban, and rural communities. We would be concerned if the eligible entity requirements limited or prevented participation by these smaller practices, such as the one that you heard about just a minute ago, working with grossly underserved patients and their families. And finally, our fourth point is who's in the eligible beneficiary population. And I want to underscore that it should be based on patient and caregiver need and not prognosis, not only because need should be the reason for receiving services, but also because it is almost impossible to predict prognosis until the last few days or weeks of life. Need for palliative care services is marked by functional decline, poorly controlled symptoms, patient or family distress can occur at any time in the course of a serious illness. It's quite common early after diagnosis of a serious illness. And should not be limited to the very small fraction of this high-need population who have a predictably short prognosis. It is also essential that the enrollment criteria be based on data that are accessible to the frontline clinicians participating in this model, like diagnosis, functional impairment, and utilization that are readily available and do not require access to claims or large administrative databases that are not available to most palliative care teams. We thank you for your thoughtful consideration of the PTAC model, and thank you for the opportunity to address you today.
Thank you. Next, Lori Bishop, National Hospice and Palliative Care Organization. Welcome.
Thank you. Good morning. I am the Vice President of Palliative and Advanced Care for the National Hospice and Palliative Care Organization. I'm also a clinician, a nurse by background, certified in hospice and palliative nursing. I've had the privilege of doing clinical care for seriously ill patients, and I've also been an administrator of programs, community-based palliative care in the Midwest, and most recently in Northern California for Sutter Health's Advanced Illness Management Program. NHPCO is here today as a founding member of the National Coalition of Hospice and Palliative Care, and we appreciate the opportunity to particularly provide feedback on the quality measures component of the PTAC model. NHPCO and the coalition strongly support the expectation that quality measures are an essential part of this model, and especially for quality assurance and performance improvement. There are three main points we want to make regarding quality measures. The PTAC survey used to obtain patient-reported outcomes and experience of care builds on the Hospice CAP survey, which is a part of the Hospice Quality Reporting Program. These NQF-endorsed measures in both models, PTAC and hospice, allow for seamless experience of care for seriously ill patients and their families. Second, the process measures that PTAC model recommends align with the NCP Clinical Practice Guidelines for Quality Care, which Diane just mentioned, and the PACC team has mentioned to you as well. These allow access to an interdisciplinary team, including social workers and chaplains, which is very important for holistic care for these patients and their families. The third point is the utilization measures include the percentage of patients that transition to hospice. We do not want to see this model become a replacement for a service you're already well established. We feel that measures that track the utilization of hospice and the connection to hospice service are essential for a model. We also recognize that there's a recommendation of patients that are served 7 days or more before death in a hospice. And we would say that this is likely an inadequate measure for patients and would recommend that actually the hospice median length of stay is a more accurate measure for those patients and could be done to also ensure that patients aren't transitioned to hospice in too long a length of stay, which we sometimes see in dementia patients today. The PACC model provides an alternate for these patients that allows for dementia patients and caregivers to get services further upstream. So we would again recommend the hospice median length of stay to track short lengths of stay and long lengths of stay. In addition, we support the broad array of entities that the PACC model allows to participate. NHPCO's member organizations participate in 50 states, including Puerto Rico, and in rural, urban, and large communities. So we are ready to participate in this model. Thank you so much for the opportunity to come before you today on behalf of NHPCO, the coalition, and more importantly, the growing number of seriously ill patients and their families who need models like this upstream. Thank you.
Yeah, thank you. Elizabeth, you had a question?
Thank you. I was actually hoping to just ask for your thoughts on, do you believe that there are improvements possible in including patients and families more in the development of the care plan so that it is done jointly as opposed to on behalf of?
Thank you for the opportunity. It's a great question. Yes, I believe the patient, we believe the patient and the family are the drivers of the care plan. So we have to sit down and find out what their needs are, and that care plan should be based on their needs. And we know sometimes their basic needs are not medical. They may be financial, they may be emotional or psychosocial. So yes, absolutely, the patient and family need to be engaged and be the driver of the care plan. Thank you.
Thank you. We now have several folks on the phone. I'd like to ask the operator to open up the phone lines, and I'll introduce the first speaker, and that's Betty Farrell from Hospice and Palliative Care, or Hospice and Palliative Nurses Association.
Good morning. This is Betty. Can you hear me?
Yes, we can.
Great. My name is Dr. Betty Farrell, and I'm the Director of Nursing Research and Education and a professor at the City of Hope National Medical Center in California. I also serve as the principal investigator for the End-of-Life Nursing Education Consortium, the LNEC project. Today, I'm pleased to represent the Hospice and Palliative Nursing Association, HPNA, the national professional organization that represents the specialty of palliative nursing. This includes more than 11,000 members and 52 chapters nationwide. Our vision is to transform the care and culture of serious illness. HPNA is a founding and current member of the National Coalition for Hospice and Palliative Care. We support the statements provided by Dr. Meyer on behalf of the National Coalition. HPNA supports the development of an alternative payment model that provides access to care for appropriate patients based on needs and not a specific prognosis or time frame, and with the interdisciplinary team of providers as described in the PACC model. I serve as the co-chair and HPNA's representative to the National Consensus Project Steering Committee that is currently developing the 4th edition of the guidelines. The NCP guidelines have served as the standard for quality palliative care since the first edition was published in 2004. The NCP guidelines describe the essential components and elements of quality palliative care. During this most recent revision process, we've heard from several insurance companies, the National Quality Forum, several accreditation organizations such as the Joint Commission and the Community Health Accreditation Partners and quality measure developers, that these guidelines serve as the framework for their standards and processes of care. And these consensus-based guidelines were widely recognized as the guideline for the provision of serious illness care. HPNA and the National Coalition for Hospice and Palliative Care commend the Academy and PTAC proposal for recognizing the NCP guidelines and outline of essential services and components needed in any serious illness model. The goal of the guidelines is to ultimately improve access to quality palliative care for all people with serious illness, regardless of setting, diagnosis, prognosis, or age. The guidelines formalize and delineate evidence-based processes and practices for the provision of safe and reliable, high-quality palliative care for adults, children, and families with serious illness in all care settings. The essential 8 domains for which experts have reached consensus are necessary for quality palliative care. It is the interdisciplinary team of nurses, physicians, social workers, and chaplains who are trained to provide these essential services to patients and families. Any serious illness model must address structures and processes, physical aspects, psychological and psychiatric, social, spiritual, religious, and existential, and cultural aspects of care, as well as care of the patient near the end of life and ethical and legal aspects of care. Thank you very much for your time and attention this morning. On behalf of HPNA and all the nurses and related personnel we represent, thank you for your consideration of support for the PTAC model.
Thank you. Next, folks, the next person on the phone is Dana Lustbader from ProHealth.
Good morning. This is Dana Lustbader. I'm the chairman of the Department of Palliative Care at ProHealth. And prior to joining ProHealth, I was a critical care physician in a large health system and also started an inpatient palliative care program. I currently work at ProHealth as chair of the department, which is a large multi-specialty group of 1,000 physicians, and we serve New York City metro area and all of Long Island, as well as some of the rural areas in the tip of Long Island and the most densely populated areas in Queens and the Bronx. Our ACO, our Medicare Shared Savings Program, ACO at ProHealth, serves about 32,000 Medicare beneficiaries. We also have 6 other shared savings programs. We serve a larger population than that, about 1.2 million patients, and do not own hospices or home health agencies or hospitals. So we're very clinic-centered, and several years ago in our ACO, invested a substantial amount of money to begin a home palliative care program. This investment was made out of some of the successes of the MSSP ACO, and we put in about $2 million to start an infrastructure for home palliative care. And in 2014, started with about 20 patients and have grown today. So we serve about 16 or 1,700 patients in their home with about 16,000 visits per year, 11,000 phone calls, and over 500 telemedicine visits to seriously ill patients in all of New York City and Long Island areas. We also serve 2 Medicare Advantage health plans for a PMPM rate. I'm going to discuss 2 things today that I think are very important. One is I'm going to describe our home-based palliative care team, and the second thing is I'm going to share some outcomes data that we've published on. So the team is comprised of a board-certified palliative care doc, and we've got several docs. We use RNs, nurses, nurse practitioners, social workers, volunteers, and we partner with the patients' chaplains, as well as partnering with all of their other doctors. And one of the things that's most striking is that many of our patients do not have a captain of their ship. There isn't one doctor who knows them. They've been in and out of the hospital or ER so often, and it's difficult to find somebody who's really coordinating their care. Nonetheless, we do communicate with many different doctors that are involved in patients' care, so that a patient might be followed at Mount Sinai and they may have their gastroenterologist at NYU, and they may have someone somewhere else. So we actually regularly call the different doctors that are involved in the patient's care. And of course, these medical records are not electronically on the same system either, so the docs often don't know what's going on with the other docs either. So we really try to be the duct tape and spackle and really make sure that that care is coordinated across the different doctors that the patients were seeing. Most of our patients, though, are becoming more frail, and it's difficult for them to get out to see these other doctors, and so very often the doc hasn't seen the patient in over a year. We also support the family caregivers, and regarding patient engagement, much of that occurs because we provide 24/7 access to care. We answer the phone. It's always a warm answer, and we do either respond with a visit, with a virtual visit with telemedicine, or the right advice and guidance as to what to do. They don't get a voicemail when they call our service. And we do really work very closely with the very burdened and stressed out family caregivers. And our social workers are especially helpful at providing family caregiver support. The next thing I want to touch on is some of the outcomes. And we did publish on our outcomes for our Medicare Shared Savings Program ACO patients that were enrolled in home palliative care. And to make this a rigorous study, we looked at only patients that died. And we compared patients that died who were enrolled in our program to those that died that weren't enrolled in the program for 2015 and 2016. And we've started now to look at that again for patients that did not die. But to be very rigorous in the methodology, we wanted to ensure that both groups had death as the outcome. And what our data showed was that the location of death for those in our program was 87% compared to about 25% with usual care. Hospice referral increased by 35%, and in fact, the hospice median length of stay increased from a baseline of 10 days to 34 days. So when they're enrolled in a home palliative care program, they are enrolled in hospice more often, and their hospice length of stay is longer. They also get to be at home in their final days or months of life, whether they're in hospice or not, because the interdisciplinary team is so good at advanced care planning and providing actual treatment and guidance as symptoms progress and escalate in the final weeks and months. Hospital inpatient admissions dropped 34% for the final month of life for people who were enrolled in the home palliative care program, whether they were in hospice or with the program and not in hospice. The cost savings in the final 3 months of life was demonstrated to be $12,000 for people who died in our program. The cost was $12,000 less than in usual care. We've started to look at a larger sample size to see if, in fact, this is reproducible. This was a study that we published in January of 2017 in the Journal of Palliative Medicine. And the one thing I'll say about the article was the second most popular downloaded article for the entire year, and I think it speaks to the interest in this space and that people really do want to figure out ways to provide care to seriously ill people and their caregivers at home. But in a fee-for-service world, it's just not possible to do that without losing money, which is also why we have pivoted a bit to serve Medicare Advantage, because we are able to provide this service to Medicare Advantage patients in our market. We have partnered with 2 MA plans. One we've partnered with for 3 years, one has been for 1 year, and we're scaling up with both of them because of demonstrated positive outcomes in folks that die, but also in the patients that don't die. In our population, 70% of patients are not terminally ill and dying, and in fact are just very, very sick with high disease burden. So they might be 87 years old with heart failure and COPD and some renal impairment and diabetes, and live alone in Queens with a daughter who works 2 jobs in the Bronx and can't get his Lasix refill, doesn't have a mechanism for that, and keeps going to the ER. So it's patients like that that aren't hospice eligible, not dying, but are high utilizers and suffering, and those are patients that we also focus on heavily in our program. So
Dana, I don't mean to
I just want
interrupt,
to stress how
we're just running out of time. So if you could please wrap up your comments, we'd appreciate it. Thank you.
Absolutely. Thank you so much. Just want to, again, thank you for considering this proposal, and it would be extremely important for seriously ill people. Thank you.
Thank you. Next is Martha Twaddle from Northwestern Medicine.
Good morning. I want to thank you so much for this really privileged opportunity to lend my voice to this space, or perhaps better said, be a container for the voices of many patients and families for whom I provided care. And I am grateful and moved by the input of this entire group, and see that you see this as relevant and timely. I am a palliative medicine physician of nearly 30 years. I see patients in all settings of care. As mentioned, I'm the medical director of palliative medicine and supportive care for Northwestern North Region. I'm also a senior advisor to Aspire Health and have been since its inception. I have the privilege of co-chairing the National Consensus Project with Betty Farrell. And soon this will be more than consensus, as we are undergoing a systematic review of the literature. This vital publication lays out what are the essential elements of quality palliative care and really speaks to the absolute critical need for the interdisciplinary team in providing care to this population. Speaks to the requirements of this team and also pays attention to transitions of care for these very vulnerable patients and families, as well as to the needs of their caregivers. My personal experience over these past 3 decades continues to reinforce the necessity of the interdisciplinary team and how critical it is to really support the quality of care for this group of patients. The multivariate needs of this patient population transcend the medical model. Historically, we have been constrained to respond to patient and family needs by sending resources that might be reimbursed. We have over-medicalized our response. We otherwise depend on philanthropy or cobbling together initiatives that are typically not sustainable. Likewise, I am daily confronted with our current quality metrics do not well reflect the needs of this patient population and their caregivers. Better are the softer measures of satisfaction, the sense of being cared for, the responsiveness of the team. This demonstration project would give us the opportunity to really bring into the light the invisible suffering of this population. I think we have so much to learn and so much that we do not know. I called to mind a gentleman just this past week, 81 years old with pulmonary fibrosis. His primary caregiver is his wife of 60 years who suffers from cognitive impairment, and her cognitive impairment is further challenged by his illness. Typically, their calls are after hours, and unfortunately, the response of EMS to their need is a mismatch and whisks him off to the most wasteful place he could go, the ED, where further testing simply confirms his hypoxia and frailty and does not meet his need and further depletes his reserve and that of his wife. So programs like we are building where we can be the first interface, the phone call is answered by a clinician, we can troubleshoot and reassure, can make a huge difference in just the utilization patterns and typically the waste in the system. The PAXI model gives vital support to provide truly essential quality care to this population. Again, I think we are on the brink of learning more as we explore the needs of this population. Mr. P, throughout his time under our care, once we got him into palliative care, did not consider himself to be dying. So I caution us always to look through the lens of prognosis, but rather to look through the lens of need. About 11 to 15% of people will get better in these programs and actually graduate back to ambulatory care and not need our services. So let's build a model that can be responsive, and I trust that we will do so. Thank you.
Thank you. I believe we have one more person on the phone, Taraya Jensen. Are you on the phone from Empath Health, Suncoast Hospice? So that may That may, it was unclear whether they actually made it. They signed up. So that ends our public comment session. I turn it back to my colleagues on the committee for any clarifying questions amongst ourselves before we go ahead and start to vote. Seeing none, we're going to go ahead then and start with our voting on the individual criteria. What's that? Rhonda. Do you want to, maybe we should take before we start the voting, 5-minute break? Okay, very good. Thank you.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.